Okay, and I'm going to be presenting some cases, and most of you will know all the answers. I am going to need your help, though, and so I'm going to be calling on some votes with the hands. But we begin with a few babies. We're talking about noisy breathing in a 3-month-old baby who came to their usual well baby check and has been noisy breathing since birth, according to the parents. He feeds extremely well, he's growing, he has no choking, he's not spitting up, he has no respiratory distress, but he does have hiccups very often. He has never had pneumonia, doesn't have otitis media, and in fact, except for this very noisy breathing that can be heard across the room, he really has no other problems. His height and weight are appropriate. He's not hypoxemic, his oxygen saturation is normal, and he actually looks quite happy. His head, eyes, ears, nose, and throat shows a normal, intact palate by putting your finger in there. He has no head bobbing as if he's in distress, no masses, and in fact, he's pretty normal, but when you listen to the lungs themselves have good air entry, but there's some loud inspiratory stridor and no wheeze. So what investigations are best? Who would like to get a chest x-ray? Okay. Who here would like to go straight to the operating room? Who would like to have a look in his airways and do bronchoscopy? Okay. Who would like to get a whole bunch of blood tests? I knew infectious disease people would do that. Well, in fact, this is what we ended up doing. We ended up looking, and here you can see the arytenoids, the epiglottis, and on this one here, we'll just start moving. There's the airway, and in a moment, you can see prolapsing arytenoids. What is this? This is laryngomalacia, extraordinarily common. It is the most common cause of stridor in infancy, probably accounting for about 3/4. You can see that prolapse of the epiglottis and the arytenoids into it, causing the vibration and the noise. And it is not the same as tracheomalacia. The larynx develops separately. This is strictly associated with the larynx. Sometimes there's also slow maturation of other cartilage, and you can check that by feeling the pin of the ear, although that's uncommon. It can occur part of cartilage dysplasia syndromes, but again, usually not. These are normally healthy children. Occasionally there's a family history, and GE reflux, gastroesophageal reflux, is common, but it's not the cause of this. It's due to the air swallowing. These children have no difficulty breathing, but with this prolapse, they gulp and they swallow air. And that causes hiccups, it causes flatulence, breaking wind, and abdominal distension. And so sometimes when you see this child, you don't really need to do the bronchoscopy. You know exactly what it is by the noise they're making and the fact that they're doing so well. And to convince the parents that I don't need to do any tests, I'll usually say, well, does he suck a bottle and you can't take it out of the mouth because he just keeps it in there? And then his belly looks like a watermelon. He drinks so much, he's full of air, and then he breaks wind. He has flatulence that's as loud as his father's, but not very smelly. And when they relate that, you explain it's air swallowing, it's common, they are the vigorous feeders, they feed well, and the stridor improves when they're prone. And they tend to outgrow it as they get older. It begins as soon as the airflow is enough to start vibrating. They're usually improved by a year, and sometimes mild symptoms can persist. Now, occasionally, this is severe enough to produce growth failure. And in that case, you can look at weight gain, oxygen desaturation, and the treatment here is surgical, where they incise the arytenoids and around there, and as it scars, it pulls down and opens up in the arytenoidplasty. So what if this is a different baby? What if this baby had vomiting every time they ate? What would be your next investigation? Who would like to do GI endoscopy? Yes. Who would like to do a barium swallow? I'll go with the gastroenterologist. Well, in fact, we did do a bronchoscopy, and what you see there, and if we can play that again, is not only a narrowed airway, but there's vibration, a lot of vibration there. And that vibration is the cardiac motion. And here is the upper GI, and you can see indentation here. And on the lateral, you can see something compressing the esophagus forward, which in turn is compressing the airway forward. So the patient has stridor because of this compression, but the food will go down and come up because of the compression there. And what is it that's pressing on that esophagus? Yes, I can see your lips moving, but I can't hear you. Absolutely, it's a vascular ring. A ring or a sling that will go ahead and compress the esophagus here, which in turn compresses the trachea. And it's fixed by separating that sling. So I'm going to give you another one. What if this baby was very premature, was in the neonatal nursery, was intubated for a period of time, and this respiratory distress was getting worse with time? And this child isn't looking healthy. This child has the noisy breathing, but truly looks like having difficulty breathing. And this is subglottic stenosis. What you see there is a dramatically narrowed airway. This is the maximal grade, that's less than 1 millimeter. And this is a less severe form. It can be congenital, but it's more commonly acquired, and it's secondary to intubation or manipulation. And it tends to occur just below the vocal cords at the cricoid ring, because that's the narrowest part of the airway. The symptoms usually begin weeks after birth and can get worse. In fact, it does get worse, and this will not grow with the child. So this is an emergency. This patient needs to have this fixed, and usually with a cartilage rib graft after doing a cricoid split, opening that so that the child can then grow with this. Because as the child gets bigger, this will not, and it will limit their airway. The treatment is surgery, laryngotracheoplasty with a graft, and often a tracheostomy to allow this to heal. So we'll move away from the babies. Actually, we're going to talk about another baby. You're in the well baby nursery, and there's a 3-day-old who hasn't passed meconium. She was born by normal delivery, 35 weeks, near term, but was a little bit small at 2.8 kilograms. When you examine her, she's awake, feeds well, not dysmorphic, afebrile, and you can see she's maybe a bit tachycardic, a little bit hypoxemic. Her abdomen is distended but not tender, but the nurses tell you she needs a bit of oxygen when she falls asleep to keep her oxygen saturation greater than 90. If you take an x-ray, her chest is normal, but you see there's as much air down there as there is up there. Abdomen is full of air, and there's none in the rectum. So let's talk about diagnosis. Does this child have reflux? Anybody? Does this child have cystic fibrosis? Got a couple, yeah. Well, in fact, children with cystic fibrosis usually don't have a lot of respiratory hypoxemia. When we do a barium contrast enema, though, what you see is skip lesions in the distal part of the intestines. And this is diagnostic of, I'm looking at the gastroenterologist, skip lesions, Hirschsprungs. Absolutely. So capillary blood gas when awake showed an elevated CO2, hypoventilation. Polysomnogram showed central hypoventilation, and the brainstem that controls ventilation was normal. So if you have central hypoventilation syndrome and Hirschsprung's disease, the diagnosis is Ferris here. And the diagnosis? Right. Congenital central hypoventilation syndrome. Used to be called Undine's curse. Undine was a water nymph. She was the daughter of Neptune. She married a mortal, which it didn't go well with her father, because if an immortal marries a mortal, you become mortal. And so he warned the young man, if you ever do my daughter wrong, I'm going to put a curse on you. And in fact, like too many men, he wandered. And so Neptune said, if you ever stop thinking about your breathing, you will stop breathing. And if you ever stop thinking about your heart beating, it will stop. And he went crazy and drowned himself in the ocean. So Undine's curse is central hypoventilation, often worse at night. Almost all of these patients have an abnormal FOX2B, which is a homeobox gene that affects the neural crest. This has an abnormal extension of the alanines, and the greater that extension, the more severe the disease. Now, the rectal suction biopsy was positive for Hirschsprung's, just as our gastroenterologist said, and the tracheostomy was placed for nocturnal ventilation. So this FOX2B is the paired mesioderm homeobox. It's a transcription factor required for differentiation, particularly neural differentiation, and it's expressed in the nervous system in neurons that control breathing, such as the respiratory system, the heart, and the digestive system. It's entirely due to this, and the mutation is required to make the conformation. It leads to both central hypoventilation and abnormalities of the crest, and the longer the sequence, the more the abnormalities. They can be diagnosed in adulthood. It can occasionally produce very mild symptoms if you have a short stretch. And these patients can sometimes be diagnosed when they go to surgery and just don't wake up easily after surgery. Usually as CO2 goes up, they begin breathing spontaneously, or they may have sleep hypoventilation. Most of the patients, though, can require long-term mechanical ventilation, daytime and nighttime, and they depend on this. And with this, they can lead an otherwise normal life. So here's the expansion. As you can see, this is the usual group, but the greater the number of expansions, the more severe the disease. And there are a small number way over here that have a non-expansion abnormality, non-polyalanine abnormality, and these also produce severe disease. Hirschsprung's is seen with those that have the greater number of problems, also associated with ventilatory support. And you can see with the non-polyalanine, you get all of those abnormalities as well as tumors in the neural crest. So management includes hospital evaluation, awake and asleep, watching them annually, assessing ventilatory responsiveness, doing a Holter monitor for their cardiac status and echocardiogram, evaluating their autonomic nervous system regulation across all nervous systems. For the patients who don't have obvious Hirschsprung's, we usually will do a barium enema or manometry to ensure that they don't have this, particularly if there's any constipation, and we image for neural crest tumors. Because most of the abnormalities are spontaneous, mutation risk is low, but there is mosaicism in up to about 10%, and if the parents have any symptoms, it's worth going ahead and screening them as well. We're going to switch gears completely again to an older child. This is a 6-year-old girl that had a stuffy nose and a headache. At the family doctor's office, they found a low oxygen saturation, and they went ahead and found this lesion down there. Am I doing that? Am I pushing a button to do that? Oh, got it. But the rest of the chest x-ray is clear. Now, they came to the doctor's office not because she appeared sick, but because they were having family over for a big Thanksgiving dinner, and Mom wanted to be sure that she was healthy. The past history was unremarkable. The sibs have a cold, mother has allergies, a cousin has neurofibromatosis, but is on no medications. So given this lesion, who thinks this child has pneumonia? I see no hands. Who thinks this child has some congenital lung abnormality? All righty. Dr. Belteton, of course. You know, when his hand goes up, everybody should put their hand up. Her height was a little bit low, but the parents are also short. No fever, no rash, no clubbing. Nose was stuffy, chest was clear, wasn't distressed at all except for her stuffy nose. She had a normal heart rate, normal blood pressure, normal respiratory rate, but her hemoglobin was high and that oxygen saturation was low. So who would like to do an echocardiogram? Well, I would, but it was normal. Absolutely. Dr. Belchertown's hand went up again. Does anybody have an idea what this is and where the blood's going? Dr. Belchertown again. Thank you. This is my advisor. So who would like to get a CAT scan? Good. Who would like to get a CAT scan with angiography? Yes. Well, she was given antibiotics by her GP and came back 4 days later, still had a low saturation, no change in her chest x-ray, no fever. So the general pediatrician, not quite knowing what to do, gave her salbutamol. And 30 minutes later, her oxygen saturation was lower. Now, in the emergency department, you'll sometimes give a patient with asthma salbutamol, and their oxygen saturation will paradoxically dip. And that's because perfusion is improved before ventilation in children. Well, she got another week of antibiotics and inhaled corticosteroids and salbutamol, and she came back and was no different, so they sent her to Dr. Belchertown. Before we get to her diagnosis, I want to talk a little bit about hypoxemia. The most common cause is mismatch of ventilation and perfusion. This is the reason for low oxygen in asthma, pneumonia, CF, and this is why there can be hypoxemia after the beta agonists, such as salbutamol, because of the improved perfusion before ventilation. Low inspired oxygen can also do this, and we had a couple of children we saw today that were borderline low oxygen, but were going up in an airplane. And as you know, commercial aircraft are pressurized at about 8,000 feet. And so if you have borderline low oxygen, it can make you hypoxemic, which is why some people with COPD will fall asleep on board the airplane. And I've been told, although I don't know it's true, that this is why people who receive the free alcohol on the flights get drunk more easily. Hypoventilation is due to low tidal volume or low respiratory rate, leading to an increase in CO2. So one of the ways we evaluate chronic hypoxemia is to ensure it's not related to an elevated CO2, as we saw in the patient with central hypoventilation syndrome. Diffusion defects or alveolar capillary gas transfer is really uncommon in children, except with fluid overload, when for some reason they're given too much fluid during surgery. But you can also see it with some interstitial lung disease, collagen vascular disease, and these are patients that have low oxygen with exercise. And finally, right to left shunt, when unoxygenated blood bypasses the pulmonary vascular bed and directly admixes with oxygenated blood. And again, consider bad data: broken oximeter, poor perfusion, poor probe placement. So this child had no respiratory distress, number one. Number two, mom thought she was getting sinusitis and wanted antibiotic before everybody came over for dinner. And oximetry was just a routine vital sign in this doctor's office. So we did do the echocardiogram. They were normal. And like I said, we always check the CO2 with hypoxemia, and this was normal. There was no oxidant or environmental exposure to things that can cause methemoglobinemia, and the lack of cyanosis made this very unlikely. But the high hemoglobin suggested she's been hypoxemic for a while and is compensating. So, just as Dr. Belchertown suggested, a CT angiography was performed showing a blackout. And here you can see, and the diagnosis is, yell it out. We have an AV malformation, absolutely. An arterial venous malformation with blood going directly from the venous system into the arterial system without getting oxygenated through the lung. And although these are present from birth, they're usually diagnosed later, often in adulthood, often associated with hereditary hemorrhagic telangiectasia. The old name was Osler-Weber-Rondeau. It's the most common associated cause of this in healthy children, usually due to abnormalities of the HHT1 gene. It includes endoglobulin on chromosome 9, or HHT2, this being much more common. This is an autosomal dominant. So if you pick it up in the child, you need to screen the parents. Because although they may not be hypoxemic, they could have an AV malformation elsewhere, such as in their brains. And in fact, if there's one, there are probably more. These children get systemic screening. This child had this fixed by coiling, by shutting off that AV malformation. But the mother had a significant one in the brain that needed clipping and could have bled and produced a significant cerebral hemorrhage. She had the HH2 mutation. She had 2 small frontal vascular. Mother and sister had the gene defect with normal X-ray. Sister had the normal MRI, but mother had a critically large AV malformation. She had it for entire life, but it needed to be fixed to prevent hypercoagulation because of the high hemoglobin. Embolization was done with these coils, and we wanted to be sure that they're not reperfused or enlarged. Check oxygen saturation with exercise as a way to make sure that these continue. She is at risk for intracranial hemorrhage and needs monitoring of those cranial malformations as she gets older. And I'm finally going to end with shortness of breath on exertion, dyspnea with exercise. We have an 8-year-old boy with a long-standing history of asthma, chest pain when he runs, but never cough or wheeze. He had bronchitis in the winter, but no other symptoms, and he's never been in hospital. But he's now really sick in the emergency department. He has cough, shortness of breath, low oxygen, and chest pain over 3 days, and wasn't relieved by salbutamol. So who wants to do an emergency bronchoscopy? Who wants to do a blood gas? Who wants to start off with an X-ray? All right. X-ray wins. He is sitting upright, wasn't distressed. Oxygen saturation was really low. Respiratory rate was high. Diffuse crackles, bounding tachycardia, but no rash, no fever, no clubbing or murmur. And the blood gas shows a normal CO2, and this looks pretty abnormal. And so when we did the bronchial lavage, these are macrophages filled with iron. And he has idiopathic pulmonary hemosiderosis or diffuse alveolar hemorrhage, and you can see the hemosiderin-laden macrophages on lung biopsy. This is potentially fatal. It can be associated with heart disease, with autoimmune disorders, collagen vascular disease. Many of these are idiopathic. The idiopathic form, like this child, shortness of breath, cough, hemoptysis, cyanosis, and often iron deficiency anemia. They can get blood in their stools or melena from coughing up the blood, and the chest X-ray often looks like miliary tuberculosis. Pulmonary hemorrhage can be primary or secondary to other illnesses, and it's often of unknown etiology, but it may be associated with exposure to the black mold Stachybotrys charatum. This patient was anemic, as expected, looked like iron deficiency with a low MCV, but there was no blood in the urine, stool, or nose. It was all in his lungs. And I'll skip that. Identify any secondary cause, give blood transfusion if needed, immune suppression with large dose steroids, and sometimes lung transplantation is needed. And do I have time for one more? You can say no. I'm set at 5 minutes, so one more, and it's going to be the last one. This is shortness of breath with exercise. We see this every year when school starts up again. This is a 14-year-old girl who has mild asthma as an infant, but has been well since. She's a very high-level swimmer and a runner since she was 10, but now she has chest pain when she exercises, especially when she does this during exercise meets, when she's competing. Her pediatrician gave her salbutamol before exercise, and she says, well, maybe it helps a little bit. But she was sent because the parents are concerned she's not going to make the Olympic team. She's not keeping up with her sports teams, but she's a top student, normal height and weight, in no distress, just the shortness of breath with exercise. And we didn't wait for the autopsy. Shortness of breath is subjective. It's when you misperceive the effort and what you're receiving. It's an afferent-efferent disconnect. So it's breathing discomfort with these two signals essentially not being effective. So that mismatch produces a sensation of shortness of breath, the feeling that you cannot get enough air. So acute dyspnea, when you're suddenly short of breath, well, that's usually easy. There you think of pneumonia, you think of foreign body, you think of all the usual causes. But chronic shortness of breath, it's a little bit more difficulty. However, the most common cause for shortness of breath with exercise that we evaluate is just being not physically fit or exceeding your own limits. I remember a girl very similar to this who was a top runner, and she said, I don't understand Dr. Rubin anymore. I get short of breath when I run 10 miles. And I said, yes, I understand. But lung disease doesn't always cause dyspnea. Children with chronic lung disease like CF rarely complain of dyspnea because they tend to limit themselves. Exercise for a baby is feeding, so babies that feed slowly could be dyspneic. And a muffled cry suggests there may be muscular weakness, but it could also be due to laryngeal dysfunction. But it's also possible to have that weak cry without visible shortness of breath. This is a very interesting study of patients that had very severe asthma, near fatal asthma, who wanted to determine their shortness of breath, whether they could perceive dyspnea. And what they did was they gave increasing resistance to healthy individuals, to people with asthma who had never ended up intubated in the intensive care, and to those with near fatal asthma. And they found that the healthy individuals very quickly could perceive the resistance and developed increasing dyspnea, whereas those with the most severe asthma could not perceive the shortness of breath. And that's why our asthmatic patients often come in late. The most severe patients don't know when they're getting ill. Exercise asthma is not associated with hypoxemia. It's an uncommon cause of shortness of breath, and it's diagnosed by shortness of breath with exercise with a fall in baseline FEV1 and no change in volumes. If they both fall, it suggests deconditioning. Exercise testing is most helpful in diagnosing it. If there's a dysrhythmia, you think of heart. If there's hypoxemia with exercise, as in this patient, you either think of a diffusion defect or poor conditioning, and we'll go ahead and do exercise testing for these patients. But it's only valid if they exercise to the point where they're actually short of breath. This patient had this loop on inspiration or vocal cord dysfunction, which is a very common cause of shortness of breath with exercise. And with that, I'll remind you, it's a perception. It could be neuromuscular, psychological, cardiac, pulmonary, and this would go along with the high expectations. And I know I'm out of time. I thank you again very much, and have a good evening.
Bien, dejamos el tiempo entonces si hubiera alguna pregunta.
Yes, see. The pulmonary, well, it was actually an AV malformation. It wasn't a sequestration. And I showed the coils, which I didn't put in. The invasive pediatric radiologist coiled these and blocked off the blood flow. And that allowed it prevented the steal, the shunting from right to left, and the oxygen saturation normalized. But we also scanned the head and the liver to see if there were other AV malformations, and would routinely follow this patient to make sure that this wasn't recannulating. But like I said, she had the genetic testing, she had the hereditary hemorrhagic telangiectasia, HHT1 abnormality, as did her mother and her sister, and so they were also followed.
Muy bien.
Again, thank you very much.
Thank you, doctor.